Dear audience, I welcome you to our another educational session. Today our topic of discussion is about imaging in ophthalmology. Yes, I'm talking about OCT and OCTA, how they have transformed our evaluation, our treatment protocols in ophthalmology. In order to discuss this, we have requested our guest speakers from United States, Professor Joseph Pizzinetti, Pizzimenti, I'm sorry. Professor Joseph Pizzimenti is a full professor and he has done doctor in optometry from Illinois College of Optometry. He completed later on his residency in ocular disease and rehabilitation optometry at University of Houston. He is a recognized clinician, educator, and a fellow of both American Academy of Optometry and Optometric Retina Society. He has also remained the president from 2012 to 2014 of Optometric Retina Society. He's a researcher, educator, teacher, and a mentor. His main field of interest is diabetes mellitus, diabetic retinopathy, age-related macular degeneration, and vitreomacular adhesions. He has got a number of publications to his credit, and he has been awarded a fellowship from World Council of Optometry in 2006. And we are very fortunate that Prof has given us time to educate our international audience about the impact of these imaging in the field of ophthalmology. So without further delay, I will request Professor Pizzimenti to please present his talk.
Well, thank you so much for that kind introduction, Professor Mirza. It's a pleasure to be here with you and with your audience, your YouTube channel today. You do a wonderful job educating and promoting ophthalmology and optometric care throughout the world. And so our topic for today, we'll talk about how OCT and OCT angiography have forever changed retina. And I want to give you my email address. It's very easy to remember. It is allthingsoct@gmail.com. And I'm happy to correspond with your audience after this webinar. By way of financial disclosure, I have no relevant financial relationships to declare. And our goal over the next 15 or 20 minutes is to provide clinically relevant information about optical coherence tomography with and without angiography in retina and macular disease. We'll go through a couple of case examples and focus on interpretation and clinical use. And so I always like to state the problem before we attack any type of condition or group of conditions. So diseases of the posterior segment are among the leading causes of vision loss throughout the world. And I like to think of vitreoretinal disease in terms of all of this new imaging as a sort of a new frontier. And this is thanks to OCT and OCTA. And I hope that we find out during this talk that these technologies are not just for the retina specialist. In fact, primary eye care physicians have now begun to fully embrace caring for patients with vitreoretinal conditions. And I saw this quote from Richard Spade in one of the retina journals. He said that most major advances in the understanding of retinal diseases have been preceded by advances in imaging. And that is so true if we go back to things like fundus photography and fluorescein angiography. The better pictures we are able to take, the more we are able to understand the normal physiology compared to pathologic disease. And so an overview of OCT and OCTA, everything is based on the B scan, the two-dimensional image that you see here on the lower left. And when we add a bunch of sequential B scans together to form a 3D volumetric cube of data, as we have here on the second frame, we can do a lot with these images in terms of qualitative information and also quantitative analysis. We're able to obtain a lot of data from these 3D volumetric cubes. One of the things that we can do with the 3D data is to provide en face OCT, in which the instrument will image the retina layer by layer, as if I am standing in the vitreous cavity, or a miniature version of me is standing in the vitreous cavity, looking down at the vitreoretinal interface, and we're able to peel layer by layer and view the structure of all of those layers in detail. And as you could see, here is the peripapillary retinal nerve fiber layer on this en face OCT. And the 3D data also gives the instrument the ability to determine these OCT angiography maps, where we can now separate the vascular layers of the retina from the superficial capillary plexus, which we see here, all the way down to the larger blood vessels of the choroid. So that, in a nutshell, is an overview of the technology. If we were to put retinal imaging onto a historic timeline, we could see that fundus photography became available in the 1920s. Fluorescein angiography came about in the 1950s, and so we were able to learn quite a bit more about the retina and its associated structures. Ophthalmic ultrasonography came to market in the 1970s. Indocyanine green technology, which is more specific for the choroidal layers, unlike fluorescein, which is more specific for the retinal layers, became available in the 1980s. And this really ushered in the digital age of ophthalmic imaging. And then in the 90s, we entered the period of the scanning lasers with the confocal scanning, scanning laser ophthalmoscope and scanning laser polarimetry. And then OCT, optical coherence tomography, was first demonstrated in a lab at the Massachusetts Institute of Technology back in 1991. And in 2001, at least in the US, the first time domain or older generation instruments became commercially available. And while I was at Nova Southeastern University in Florida, we were among the first clinics to adopt this technology. 5 years later, in 2006, Fourier domain, also known as spectral domain OCT, became commercially available. And this newer generation of optics greatly enhanced visual resolution and scanning speeds. OCT angiography became commercially available in 2015. And I'll tell you, Dr. Mirza, at that point, I was not terribly impressed. But fortunately, a lot of good things have happened in the decades since, and OCT angiography has made great gains within the last decade. Swept source OCT, which is another type of Fourier domain OCT. So we're thinking here about wider field of view, scanning deeper and wider and with even faster scanning speeds. And this became available in 2016. And that's pretty much where we are today. And so we could separate these imaging technologies into the invasive methods, where a dye is injected into the antecubital vein, either fluorescein or indocyanine green. And then on the right-hand side, we have our non-invasive technologies with OCT and OCTA leading the list. But if we combine it with any one of these other imaging methods, then we now have multimodal imaging, which has become very common in eye care. I do want to emphasize that while these retinal imaging methods are wonderful, they do not replace a traditional dilated retinal examination. So the wide field imaging and the OCTA should not be used in lieu of a traditional retinal exam, but in addition to a dilated retinal examination using a binocular indirect ophthalmoscope, condensing lenses, sometimes scleral depression, perhaps three-mirror fundoscopy, all types of contact and non-contact lens fundoscopy, along with the slit lamp. So you still must be a good clinician, a good examiner. But as you could see from the very crude OCT images that we had in 1991, a lot of good things have happened in 30 years of OCT. And so we don't have time to talk about all of these applications, but one of the reasons that OCT has become such a workhorse in our clinical armament is because it has many applications, from the vitreous and the vitreoretinal interface to the neurosensory retina, the RPE Brooks membrane choriocapillaris complex, the deeper blood vessels of the choroid, and of course the optic nerve and its associated structures, including the retinal nerve fiber layer, the ganglion cell layer, and the inner plexiform layer. And this is just posterior segment OCT. Nowadays, anterior segment OCT is getting better and better as well. And so we do need to know our anatomy. So anatomy is to physiology as geography is to history. It describes the theater of events. And I've put these slides in just for your own audience's benefit and as for a self-review. I want to thank Dr. Curcio for sharing this slide with me of the histology superimposed on the OCT imaging to show those retinal anatomic correlations. And Professor, I'd be happy to share these slides with you in a PDF format after the webinar, and you can distribute it to your audience. I do want to mention this ellipsoid zone band, and we'll talk a little bit about biomarkers, but this ellipsoid zone band right here can be thought of as a biomarker for visual function. When this band is intact, visual function tends to be very good, but when this ellipsoid zone is contaminated in some way in this foveal area, visual function will suffer. And so it's been used in clinical trials and other studies, as well as just in clinical cases to determine, well, does the visual acuity match the pathology? And there is a standard nomenclature for OCT and now for OCT angiography, and you can look up these articles and become more familiar with that standard nomenclature. In the beginning, it was like learning a new language. And I also want to impress upon the audience the importance of the coronal scan or C-scan. We spoke briefly about en face OCT, where we can look at these slabs and we can click and drag these two purple lines to move it up and down. And for instance, here is an epiretinal membrane as we zero in on the vitreoretinal interface. And if we look at our en face slab, we can clearly see the striations here. And we could also see the dark areas, which indicate partially non-adherent epiretinal or epimacular membrane. And then below that, on another eye of a patient that is 6 weeks post-op, if we bring the cut a little bit further down, we can see in the mid-retina these cystic spaces. And so for conditions such as epiretinal membranes and cystoid macular edema, OCT has almost replaced fluorescein angiography. And so, yes, we are doing more and more OCTs and OCT angiography, and we are doing less and less true angiography with fluorescein and indocyanine green. But there are still some advantages to traditional angiography that I will talk about a little bit later. And so OCT has forever changed the classification and management of disorders of the vitreoretinal interface. If there's one area in retina where it has really revolutionized care, it is in the area of macular holes, epiretinal membranes, vitreomacular traction syndrome. And so we all know that as time marches on, certain changes take place within the vitreous humor. First of all, it will liquefy, and that liquefaction of the vitreous is known as synchesis. And then the vitreous, the collagen in the vitreous will clump together, shrink, and move forward. And this process is known as syneresis. The problem is the synchesis doesn't necessarily occur at the same time and to the same extent as the syneresis. And what we are often left with are these vitreomacular adhesions, which in this case of this patient, a 60-year-old female, has resulted in vitreomacular, vitreofoveal traction. And this is the typical scenario. The vitreous will separate from the retina on one side of the fovea and then on the other side of the fovea, and it will often remain stuck right here in the foveal center and also around the optic nerve head. And so when it comes to these cases, we try to reassure the patient who's now seeing about 20/25, and we let them know that oftentimes just watchful waiting, seeing the patient in a few months, will result in eventually complete separation of this partially attached PVD, and then the retina will lay back down. Now, on occasion, this traction will be persisting, and in those cases, we can end up with the epiretinal membranes and macular hole, which we see right here on another patient. So here we have the lid of this vitreofoveal traction opening up, and now we've got a small diameter but full thickness macular hole. And we could see some of these intraretinal cystic spaces developing. And so now our stage 1 macular hole has become a stage 2 macular hole. And so now this becomes a surgical case. So OCT has really validated all the work that was done by Dr. Gass, one of the fathers of macular disease in the United States. And amazing, he was able to come up with his grading system without OCT. But the OCT has really caused us to make more informed referrals to retina specialists for vitrectomy surgeries. In another patient below, we have another small diameter but full thickness macular hole. But in this case, that PVD is now completely separated. This is also a surgical case, but you could see the pseudo-operculum floating anteriorly to that macular hole. And so the ability to image these structures has been just a godsend. And so here we have a 59-year-old white female with a full thickness macular hole. You could see that we've reversed the contrast on our OCT. Sometimes it helps to see the little break a little bit more easily on our negative OCT. And then here we have spectral domain OCT done on a postoperative patient on day 1, and we could see a little bit of hyper reflectivity at the vitreoretinal interface. And if we were to look at this ellipsoid zone band, we could see a little bit of disruption of that band. So this patient is seeing about 20/30 or so on day one post-operatively, which is still a really good result, 20/30 to 20/40, but there is no foveal depression on this particular cut. Whereas at 5 months in the image below, we have the foveal depression has returned, as has the ellipsoid zone band, and so visual function will improve on this particular case. OCT and OCTA have forever changed the classification and management of diabetic retinopathy, and especially diabetic macular edema. And of course, DME may occur at any stage of diabetic retinopathy. So this is a patient with, I would say, moderate non-proliferative diabetic retinopathy, but extensive diabetic macular edema. And a number of things are driving this maculopathy and this macular edema. This patient is overweight. They are a former smoker. They have sleep apnea. They have hypertension, and so forth. So it's more than just the glycemic status that is driving the retinopathy here. And so with our 3D volumetric cube scan, we get a lot of data, including a near infrared image, a thickness map that is superimposed on this image, 9 zones where the average retinal thickness has been calculated, and these 9 zones are based on the original early treatment of diabetic retinopathy studies. And so we can scroll up and down and temporal to nasal and see what that diabetic macular edema looks like on our B scan below. And so there are really 2 types of diabetic macular edema. We have this diffuse sponge-like macular edema. And here we could see these hyper reflective hard exudates that we see on the multimodal imaging. We have some disruption of the ellipsoid zone band here. And we could also have more focal macular edema. And this may guide the treatment methods as far as which anti-VEGF agent the retina doctor will choose to treat these cases of DME. And again, we have obliteration of that ellipsoid zone band in the cystoid form of diabetic macular edema. And, you know, we all learned this system in school, and we still teach this for those few practitioners out there that do not have access to OCT, the definition of clinically significant diabetic macular edema, but it is an older criteria. And now in the era of OCT, what we are concerned with, number one, is there any edema within this macula? And if so, does the macular edema involve this central subfield? And so our definition of diabetic macular edema has been updated to take into account the central subfield in OCT. So we would call this, for instance, center-involved diabetic macular edema. And this is a patient of ours in the retina clinic. This was their first visit several months ago. They are receiving anti-VEGF injections on a regular basis. Here was their previous visit, and the technology does a nice job of isolating those areas where we still have increased retinal thickness correlating with these hyporeflective pockets of intraretinal spaces. And on the current visit, it's fairly stable, although there is still some residual edema. And so we are using OCT now to determine whether the treatment is working. What is OCT angiography? This is an extension or an application of optical coherence tomography that provides non-invasive angiograms of retinal blood vessels, choroidal blood vessels, and also vessels that supply the optic nerve. Unlike intravenous angiography, this is completely non-invasive. It allows for rapid image acquisition, for repeat scans, to follow for progressive disease versus stable disease. So we can now assess blood flow layer by layer. And this is the big advantage of OCTA. It allows a separate evaluation of the retina and the choroidal plexi. And these vasculature cannot be separately visualized by any other technology. And as I said, it's fortunate that, those early OCT angiograms have been improved so much that nowadays here is a healthy perfused fundus composite with all of the layers on FOS OCT angio. And here is a highly ischemic retina in proliferative diabetic retinopathy. And of course, vascular endothelial growth factor is being secreted in all of these areas. And so, the technology is becoming more and more wide field. We still use montage to get a wider field of view, extending the reach of OCTA. And here is just an example from some patients in our clinic of OCT, structural OCT showing neovascularization of the disc, structural OCT showing neovascularization elsewhere on the retinal surface, and OCT angiography of these areas at the level of the vitreoretinal interface, where we can see this neovascularization elsewhere and neovascularization on the optic disc, as well as areas within the foveolae vascular zone and around the foveolae vascular zone of non-perfusion. Microaneurysms become fairly apparent here as well. And so when I look at a fovea like this, even if maybe on fundus examination, I'm seeing mild non-proliferative disease, we still have a certain degree of foveal ischemia. And this might make a difference in my surveillance of this patient. I may see them a bit more frequently, but also really emphasize nutritional therapy and diabetes patient education. So we have microaneurysms, alterations in the foveolae vascular zone, and neovascularization. And it used to be thought that diabetic retinopathy was really a condition of the posterior pole, but I think a lot of research that has been done on wide field and ultra wide field imaging, wide field OCT angiography, wide field fluorescein angiography has proven that diabetic retinopathy is not exclusive to the central retina. This patient here also has glaucoma in the right eye. And anytime we see this pre-retinal hemorrhage here, this boat-shaped hemorrhage, we know that there is neovascularization. And we have other alterations like these loops and IRMA and so forth. So we have OCT that goes beyond the posterior pole, OCTA. Some other examples in PDR where all we have to do is to bring these yellow lines upward to really isolate these vessels. And with the red blood flow overlay, it's fairly easy to find certain areas of neovascularization. Of course, OCT and OCTA have forever changed the classification, the diagnosis, and management of age-related macular degeneration, especially the neovascular form of AMD. So we can look at this case of a 76-year-old patient, also has glaucoma, and we have been following this patient fairly frequently for intermediate dry AMD. But on this particular visit, the acuity in the left eye has reduced from 2025 to 2040, and the patient has been complaining of a worsening of the central vision. Here, once again, we can see the notching of the neuroretinal rim. Patients are entitled to as many diseases as they like. It just so happens this patient has glaucoma and the neovascular form of AMD, which becomes more apparent on OCT angiography, as we can see the neovascular complex right in here. Swept source OCT, I'll just briefly mention it. Again, much faster scanning speeds. Its main use is imaging through cataract. Here we could see a cloudy fundus image because we're going through cloudy media. But the OCT on swept source is able to detect suspected areas of type 1 choroidal neovascularization, which is underneath the pigment epithelium and now leaking fluid into the subretinal space, and a type 2 choroidal neovascularization that has also pierced the pigment epithelium and is now invading the subretinal space. So swept source OCT, another image here showing choroidal rupture, traumatic choroidal rupture. I'd like to thank Dr. Haney for sharing this image with me on multimodal imaging. And of course, this eye will always be at risk for two things: choroidal neovascularization, which we do not have on this eye, but also this eye is always at risk for traumatic glaucoma, right? Angle recession glaucoma. So we must periodically perform not only OCT and a dilated retinal examination, OCT angiography, and gonioscopy on both eyes. So to summarize, contemporary imaging provide valuable information about tissue morphology, vasculature, and stability versus progression of disease. We combine all this information with our history, our fundus exam, and don't forget functional testing to enable more accurate diagnoses and make better informed decisions with respect to referrals to subspecialists and monitoring and surveillance. So indeed, OCT and OCTA have forever changed retina. And of course, we'll end the presentation by showing you my two favorite singers, the late Frank Sinatra and also Andrea Bocelli, and my email address. And I did take some of the questions that you and I discussed, and I put them into some slides that you and I can discuss if you would like, Professor Mirza.
Thank you, Prof. It was very beneficial presentation, and you explained everything in detail. One thing, Prof, when we talk about this, uh, about the OCT and OCTA, if we talk about the future in quantifying vascular metrics for AI-driven biomarkers, where do you think the most important area will be? Whether it will be understanding neurovascular coupling in glaucoma or applications in neurology, systemic diseases? Where do you see the future, Prof?
This is very exciting. Yes. And I think this is where a lot of the clinical research is going. And I think where OCT and OCTA can continue to make an impact, whether we're talking about neurologic conditions like multiple sclerosis. Again, we talked about biomarkers on OCT and OCT angiography of not only ocular disease, but systemic disease, heart disease, neurodegenerative disease, even chronic kidney disease. So I think this is a really exciting aspect of the clinical applications, and the convergence of AI and machine learning and bioinformatics with the imaging. The term oculomics or oculomics has popped up in the literature the last few years, and really the eye is certainly a mirror of systemic health and systemic wellness. Very exciting stuff.
Well, Prof, it was a very exciting session with you. We learned a lot about the history, about the basics, so many things we don't know, but you explained in detail. We are thankful on the behalf of our international audience and looking forward to more sessions to get benefit of your experience, wisdom, and knowledge. Thank you once again from my all audience, Prof.
It's been my pleasure. Take care.